Good morning, everyone. It's been a little hectic morning, but for the most part, I just wanted to welcome all of you and to say thank you for coming. Our conference here every year is geared to families in whatever part of the neuroblastoma journey you're on. So if you're newly diagnosed, if you've relapsed, we have survivors and we have angel parents. The whole point of this conference was my son was diagnosed with neuroblastoma in 1995. Unfortunately, he passed away in 99. And one of the things that really bothered me about the whole process really was the lack of education back then. And we're talking no internet at that point. I had a photocopy of something, and that was my resource material. So that's the reason this conference is here, is to provide all of you with the necessary information for as many treatment options as you can possibly get. We try to do it in an unbiased fashion. We don't, support one doctor or one hospital over the other. We want you to get information from all perspectives and all researchers. We just find this to be very important. So you can go back to your, place of treatment and ask questions. Start asking questions, because that's the only way I think that you're going to get the full benefit of the conference, is to be able to ask the questions necessary to make informed choices for your child's treatment. So again, that's the whole point of this conference, and we're just very, very glad that you're all able to be here, whether or not we were able to help you with travel assistance or gas cards or whatever the case is. But it was important that we made it accessible to everybody. So again, thank you for coming. I want to thank our sponsors for the event. United Therapeutics has always been, there for us every year. A couple of the people from United Therapeutics are there, and if you could stand up and if we could give them a round of applause, we really appreciate their support. We have another one of our sponsors that's here today. I asked her, they've sponsored the event for several years now through golf outings for a local family here in Chicago. And I asked her, I said, you've got to come and see this. I want you to know where your money is going. And I would like to introduce Erica Rauscher from the Thank Foundation in New York. We just got a new sponsor, YMABS, out of New York, right? And we have Steve and Edie, and then I think there was someone else from YMABS. So if you could stand up, and again, thank you very, very much for your support. We have the Nick Foundation out of New York. We have Arms Open Wide Foundation, and from the generous donations of our families and your co-workers and friends. The way the conference is working, we do about a 30-minute presentation by the speakers, and then we're going to do a 15 to 20-minute question and answer session after each speaker. We ask that you do keep the questions general in nature rather than going, some of the things you're going to have to ask because it's very close to you, but at the same time make it general so that other people can learn from, your question and the doctor can answer them. If you have children, they'll be down in the kids' room, which and if you haven't been here, again, if you're kids, please don't go down there unless you get called or whatever, because when you go down there, they get real crazy and they want to get out and stuff like that, and they're going to be very, very, very busy. So they face painter and everything. They'll have a great time. And let's see, and I wanted to thank Kenna Anderson, who runs the kids' room, for being here and running it year after year. I want to thank Nikki DiBenedetto, my assistant, for putting together all the flights for everybody and taking care of Facebook and doing everything for us that way. I'm the figurehead, she's the worker. And then also for Connie, Tracy, my friend, she helps out all the time too. So again, thank you so much for being here. And our first speaker, because we're kind of running late here, so I'm just going to go ahead and get going, and I'll make other announcements as we go along. Our first speaker is Dr. Andras Heczey. Dr. Heczey did his undergraduate work in medical education in Budapest, Hungary. He did his residency and internship at CHLA, Children's Hospital Los Angeles, and his fellowship at Texas Children's Hospital in Houston. He has co-authored numerous publications and articles on neuroblastoma, and his talk today is going to be the new trial that's being conducted at Texas Children's. Dr. Andres Heczey. They forgot to give us the microphone, so we have to use that.
Well, thank you, Pat, very much for the kind introduction, and I'm really honored to be here with you today. This is a fantastic meeting. I had the opportunity to participate a couple of years ago, and it's really a unique place to interact with you all and try to show some of the research that we are doing at Texas Children's. So with that, my talk is going to be focused on a new clinical trial called GenaKit-2 that is evaluating natural killer T cells which are genetically engineered to express a GD2 CAR and interleukin-15 for children with relapsed and refractory neuroblastoma. I do have some disclosure. I'm inventor on the patents that related to chimeric antigen receptor design and the NKT cell platform. The NKT cell platform is now licensed by Cellmedica, and I do receive research support from Cellmedica. And obviously, this is an investigational approach that I'm going to be discussing. So, for many years, conventional chemotherapy and approaches based on that has been really dominating cancer therapy. But in the last couple of years, more of a decade now, immunotherapy has been moving to the front stage. There are different types of immunotherapies, and my talk is going to be focused on adoptive cell therapy or cell therapy or CAR T cell therapy. You will see different. You're probably familiar with different variations of this. And here, the important thing is that what you're trying to accomplish is to train the human immune system that can fight cancer or infections to recognize the cancer cells and eliminate them. In adoptive cell therapy, we draw blood from the patients and collect white blood cells, genetically engineer them, and infuse them back to the patients after kind of training them in the laboratory and expanding them to a larger number with the hope that then these newly trained cells can eliminate the cancer cells. Well, there are different types of blood cells, and white blood cells are not created equal. There are different types of them. The one that we are interested in, the one group that we are interested in is called lymphocytes. And even within lymphocytes, there are different subtypes, and I'm going to get there just in a second. But what we try to do in other centers as well is to genetically engineer these lymphocytes by using usually viral strategies. We insert a gene of interest into these lymphocytes, and when the gene is actually kind of retraining the cell, certain molecules can be expressed on the cell surface. The molecule that we are very much interested in is called CAR, chimeric antigen receptor. You may be familiar with this term already. So these molecules now come in different size and shape and different generations. What you have to kind of remember is that these sit on the cell surface of your cell, in our case NKT cells, and the outside part of the molecule is capable of recognizing the cancer cell. And when the cancer cell is recognized, these lymphocytes, these genetically engineered cells, using the inside part of the molecules, can be activated. And that activation should trigger killing the cancer cell and the division, the replication and expansion of these genetically engineered cells, thereby kind of increasing the number of your soldiers to fight cancer. So this is what I kind of just described, that the CAR T cells or CAR NKT cells will engage the tumor cells, recognizing specific molecules on them. And if things work out well, then the cancer cells get destroyed. And of course, it's very important that then in return, the CAR T cells or CAR NKT cells will expand and continue to fight other cancer cells, and then of course last long and make sure that the tumor cells can never come back. So this approach has gained a lot of attention recently because they seem to be really effective in leukemia patients in particular, so some certain types of blood cancers. But with solid tumors, we are not quite there yet. And there are several barriers that is kind of holding the field back for effective solid tumor targeting immunotherapy using CAR T cells or CAR NKT cells. And I just listed a couple of them. And neuroblastoma being a solid tumor, these are the barriers that we kind of have to focus on. And we are hoping to address some of these with the current trial. So one thing is the limited number of promising and safe target antigens. We are targeting GD2, and you're all probably very familiar with GD2. Targeting GD2 with antibody is quite effective, but it does have some side effects. Pain, I think all of you are familiar with. It seems that when targeting with cells, with T cells at least, that doesn't seem to be the case. And I'll show you some data with NKT cells that maybe that doesn't happen either. The type of cells that we are using for targeting the cancer cells seems to be very important. Even within white blood cells, even if you are looking at lymphocytes are not all the same. We are very much interested in natural killer T cells, which is a unique type of lymphocytes that has special properties that makes it attractive for neuroblastoma immunotherapy. And then for the expansion of these cells, there are certain other molecules that are important. IL-15 and IL-21 help the engineered cells to survive in the hostile environment of the tumors. So cancer is very tricky and will fight back. So we have to be ready to evade the cancer cells and make sure that our cells can survive. And we are using interleukin-15 currently in the clinical study to overcome the tumor. And the tumor microenvironment is really difficult to overcome. And I think overall we don't exactly know what happens in humans when the tumor cells are under attack from CAR T cells or CAR NKT cells. So we are also examining the tumor microenvironment post-infusion in every patient. Okay, but why are we using NKT cells? And as I alluded to, NKTs have some special properties that make them really attractive for neuroblastoma-specific immunotherapy. If you look at patients with stage 4 neuroblastomas, the presence of NKT cells is associated with improved outcomes of these patients. But why is that? NKT cells actually do not target neuroblastoma directly. So how can they still make a difference? Well, it turns out that there are other white blood cells in neuroblastomas. And neuroblastoma is not just cancer cells. There are all sorts of other cells there that are interacting. And at the end, the ultimate sum of that interaction is that the cancer is continuing to grow. One of these infiltrating cells is called tumor-associated macrophages, or TAMs for short. And these TAMs are actually able to help neuroblastoma cells to grow. Well, it turns out that NKT cells can localize next to these TAMs, next to these macrophages, and eliminate them. So Dr. Metalitsa's group has shown it in several preclinical studies already, how this actually happens and what is the mechanism by which NKT cells eliminate these macrophages. And it turns out that when there are a lot of macrophages in neuroblastoma tissues, those patients don't do well. So we think that there's this indirect attack on the neuroblastoma supporting stromal cells or macrophages that really helps NKTs make a difference. What's also important is that T cells, although are the kind of the gold standard right now for immunotherapy using CARs, but NKT cells can better penetrate neuroblastoma tissues than CAR T cells. So even if the T cells are compared directly with NKTs do better. If we express the same CAR, the same GD2 CAR in T cells, the CAR NKT cells will penetrate the neuroblastoma better. So that's very important because obviously the cells have to get there in order to fight cancer. So with that, we had the idea that we will generate different molecules, different types of this CAR, and engineer NKT cells to see which which CAR molecule is working the best. So here I just want you to focus on the red bracket. Those are kind of the codes, how we name these molecules. And the key here is that we use different signaling molecules attached to them that are expressed in the inside of these NKT cells that can help them survive longer. And we also attached interleukin 15 into this structure. And you see the map of the gene that is being inserted into every single cell. And then we try to see if these cells express, these receptors actually express in the NKT cells. So without going into the details, the good thing was that all of these receptors, after engineering the NKT cells, were found on the cell surface of the NKT cells. So that was good. But pretty soon we had to realize that the one on the second row that has BB in it, in the abbreviation, those receptors actually trigger an activation-induced cell death in NKT cells. So those NKT cells would not grow well. So obviously we wanted to make sure that we focus on the most promising ones for further clinical development. So with that, we tested in a number of xenograft murine models when human neuroblastomas are growing in animals. We wanted to test first if we inject NKT cells expressing these CARs, which type of CARs will induce the best expansion of NKT cells. So here you see various pictures of treatment groups, non-transduced is up here, or just with interleukin 15, or the CAR and the CAR plus interleukin 15. And the coloring is detecting or representing the number of NKT cells present in the mice. So the more color you have, the more they are expanding, and that's what you're looking for. So what we found that if this CAR is expressed in NKTs together with interleukin 15, the other molecule that should be helping them survive and expand, they seem to be expanding the most, and this was statistically significant. And we can detect them up to 3 months. They don't cause toxicities to the mice. They sit in the liver, the spleen, the bone marrow. So in many places where you can actually find that neuroblastomas metastasize too. What was important is that when they penetrate the bone marrow, and we can see that the presence of interleukin 15 really helps these NKT cells survive there. Okay, well, that's important. They have to survive in the bone marrow. That's where neuroblastoma can metastasize. What we also found is that if you look at then the presence of whether there is still neuroblastoma left in the bone marrow, well, if our interleukin 15 is there, it's still there. Neuroblastoma still can be found. But what's important is that if the interleukin 15 is co-expressed with the CAR, then the neuroblastoma is also eliminated from the bone marrow as well. So that was very promising. But ultimately we wanted to see if, and we looked at 3 independent neuroblastoma models. I'm showing you the one where human neuroblastoma is injected IV, so it creates a pretty aggressive metastatic mouse model using human cells. And those animals were then injected with different types of NKT cells, different treatment groups. So without engineering, with expressing interleukin 15, which is a molecule that will help them maybe survive longer, but obviously cannot help them find the cancer and eliminate cancer. On the other hand, if the CAR is expressed alone, you do see some anti-tumor activity. But what's really key is that if the CAR and interleukin-15 is expressed in NKT cells, and these cells are injected in tumor-bearing mice, the mice do much better, and there's a significant survival advantage with some cure also detected in these mice. Again, we've done this in several other setups and found similar or actually sometimes even better results. So with this and obviously some other results, we continue to evaluate the strategy, or are still continuing in the clinical setting, in a phase 1 study called the GenaKit 2 trial. So this study now started to enroll patients with relapsed and refractory high-risk neuroblastomas. The study incorporates lymphodepletion, which is a type of chemotherapy that kind of prepares the patient for the NKT cells to be infused and helps the CAR NKT cells to expand and survive longer. This is kind of standard now for cell therapies and is not aiming to eliminate the tumor cells. The study is using a standard dose escalation strategy on the 4 dose levels. We are currently on dose level 1. Obviously, this is the first in human trial evaluating genetically engineered NKTs, so our main objective is to make sure that this is safe. We want to know if the CAR NKT cells are persisting in patients and that they are trafficking to the tumor sites, and what they do at the tumor site is also important. And then, of course, even in the context of a phase 1 study, we want to see if there are anti-tumor responses. So just briefly, the study is run in 2 phases. The phase kind of 1 or part 1 of the study is called procurement. In this case, the white blood cells are collected from the patients through an apheresis procedure. This is all done outpatient. We see the patient in the clinic for a visit, make sure that he or she is ready, and then the apheresis is done on the next day, outpatient again, and after that, we manufacture the cells. Now, our manufacturing time is actually down to 9 days, but the testing is still taking several weeks after that. So we have about 4 to 6 weeks from the time of procurement to actually infusion, which is the second part of the study called treatment, and that's where the CAR T cells are infused. And I have a schematic here showing the first 3 days of lymphodepletion, followed by the infusion of the CAR NKT cells, and then the clinic visits for evaluation moving forward. I want to point out that at week 2, there is a biopsy also in the study when we are using minimally invasive strategies, taking a piece of the tissues to the tumor tissue, trying to see how the cells are interacting and whether there are any escape mechanisms employed by the tumor. So thus far we treated 3 patients. All had unfortunately relapsed refractory, widely metastatic disease. All were on the first dose level. And the 3rd patient is in the 2nd week follow-up, so I won't be able to show any results on him. Doing really well so far, but obviously the data is just not mature enough. Just wanted to show you some plots on the products that were generated. The first patient had a pretty good number of CARs on the cells. So these are flow cytometry plots that are showing how pure the product is. So about 94% of the cells that were infused into the patient were NKT cells. And of those NKT cells, 34% expressed the receptor. So that's quite good. We want to be above 20%. The second patient had similar good purity, but the number of the expression of the receptor was not that high, but still good enough. And keep in mind that was patient 2, and I'll show you some anti-tumor response data in just a second. So first and foremost, we found that the infusions are thus far safe. We do see some toxicities related to the lymphodepleting chemotherapy, and this is expected. We know and we want the blood counts to be dropped. And so obviously the lymphocyte count decreases significantly, and that is good. We want the patient's lymphocyte count to be dropped, so what we infuse then has a better chance of expanding. And we did have some other really mild side effects as well, but thus far we are quite happy. One thing I want to point out is back pain. Obviously, targeting GD2 makes us very nervous about pain, but I have to mention that this patient is very much into Fortnite. I'm sure many of you are familiar with. He started playing Fortnite on Friday late afternoon and played until Saturday morning and was complaining of back pain Saturday the whole day. I'm not sure if it's really the therapy that caused it, but we are going to report it just to be on the safe side. All right. So this is a busy slide, but let me try to walk you through it because we really want to make sure that NKT cells can expand in patients. That's really a strong correlative to anti-tumor activity, at least in the leukemia world. So before infusion, here you see that this patient barely has any NKT cells circulating. And keep in mind, that's kind of normal. Most of us have 0.1% or even less NKT cells circulating in our peripheral blood. That's a challenge for us to collect and manufacture a lot, but there is also an advantage because these cells tend to traffic to the tissues, including neuroblastoma. So as long as you can make them, then they should go to most of them should go to the tumor sites. So at the beginning, there is none of them circulating, but after infusion, week 3, you can see a pretty significant expansion. I'm not sure if I'm pointing at the right, yeah, here you go. Pretty significant expansion and enrichment of NKTs in the peripheral blood. And some of them express the chimeric antigen receptor as well. If you look at the two patients over time, at the beginning, there's very limited number of NKT cells circulating, and then those numbers for both patients go higher. What's important that at the beginning, obviously, there's barely detectable CAR NKT cells, and especially in the second patient, you have a pretty robust expansion up until week 3, and even they were detected at week 4 at pretty high numbers. So that is really, really promising that even though we are in dose level 1 and infusing cells that are known to traffic to the tissues, we are still able to detect them, and they are actually expanding all the way to week 3. The other important finding was that we can detect the NKT cells at the tumor site, and so here if you look at 2.1% of lymphocytes in the tumor were NKT cells, which is a quite high number. And what we also noticed is that a larger proportion of these cells, 85%, are expressing the CAR on them. So it's quite interesting. As well as we also looked at bone marrow aspirate in one of the patients, and we also saw some enrichment of NKT cells. Although in this case, the receptor was not expressed in very large proportion of those NKT cells. I'm not sure why, but obviously more patients need to be evaluated to have enough numbers to make a conclusive idea out of this. And then, of course, so we are able to show at least in 2 patients that the approach is safe. The cells are expanding. They traffic to the tumor and to the bone marrow. But does this make any difference? So the first patient that we infused had very high disease burden. I assume you are all familiar with Curie scores. His Curie score was 23 and had stable disease. The second patient had a less disease burden, had 2 MIBG-avid bone sites, and I'm showing you the SPECT images of the sternal lesion. That was a relatively larger mat that was detected prior to infusion. So, there are some artifacts for MIBGs. The heart, the liver, the salivary gland always picks up MIBGs. So this is not tumor, or down here is not tumor. What the arrows are pointing out is actually the tumor. After 4 weeks, we see a dramatic decrease in the size of the MIBG uptake and in this patient's sternum. And actually at week 8, there was no additional infusions, there's no chemotherapy given, the regression of the tumor continued to go. And in fact, the original read was that the patient is in complete remission. You can imagine how excited all of us were, but at the end there was still some residual disease there. So this is quite promising, but obviously this is one patient, 2 in total. So although promising, we obviously have to have more evaluations to have a better understanding of the anti-tumor activities. And with that, just to want to make some concluding statements. So it does seem that CAR and KT cells localize in preclinical models much better than CAR T cells to the tumor. In our models, the CD28, the activating molecule inside the CAR with IL-15 triggered better expansion and better anti-tumor activity in preclinical models of neuroblastoma. We can manufacture CAR and KTs to clinical scale in GMP, using GMP standards. And thus far, the infusion of CAR and KT cells have been safe. There is evidence of in vivo expansion in patients. There is evidence of localizations to metastatic sites. And there is one patient with quite exciting tumor regression. So with that, obviously, I want to acknowledge those who really, really help, most importantly, patients and families. I know that it's a big ask to come to TCH, but we can't do this without you. Leonid Metalita has been pioneering NKT cell therapies for decades now, and there's a lot of folks working in the laboratory to make this happen. I will have to leave relatively soon, so I wish, but I could, but I won't be able to answer, questions after the talk. But please feel free to email me, and I'll do my best to answer your questions to my best of knowledge. And well, that's it. Thank you very much for your attention.
Thank you, Andres. You have a few minutes, or you don't?
I do, yeah.
Oh, okay.
Right now, but
We have 2 microphones set up, one over there and one over there. So if you have any questions, please. Oh, you may. I don't know if it's on. You may have to turn on the bottom. You have to turn something on. Okay, Brandon. Yeah. Check and see if it's on. Okay.
Dr. Heczey, thank you for coming out. I know how busy you are. Obviously, I'm a little bit biased towards you. Right there at the end of my son's fight, you represented all the hope, and he himself expressed his hope into getting to your trial. And that's the basis of kind of where my question will begin. And while the crowd may be small here, we do rely heavily upon what is being taped here, so this answer could help out potentially all those that are at home and not able to be here right now because they're dealing with whether it be relapse, refractory, or frontline treatment. So when my son relapsed, there were decisions that were made that had to happen very quickly. Obviously, disease burden has to weigh in. I don't want you to speculate because I know you'd prefer not to be on camera speculating, and I know you love your work and you have confidence in it. That being said, there are some choices that we make very quickly and rashly, it seems rash as parents, that would make our kids or your patients not primary patients for this study. I know you want to steer a certain way, and unfortunately you're getting a lot of kids with heavy disease burdens. What would you say to the families out there who want to line up the best possible way to treat without having to go down a road of such heavy toxicities? So for instance, when I got to you, our liver levels were too high, and his thrombocytopenia was just too much to overcome for us to get in. But that was due to some decisions we made in previous treatment. Yeah. That being said, do you feel that your results would benefit obviously from less burden in the initial stages of what you're trying to do? And what can we do to understand how to get you more patients so that you can get some more criteria in front of us? How would you direct that type of thought process for us let's say after a relapse and scans with Curie scores of what? You know, if there was an ideal, and I know you can't choose this, but Julie Park did studies that were similar with heavy disease burdens, and things did not pan out. So a little bit of it, if you could expand a little bit on that.
Yeah, so this is hard. I think for not just for this study, but for any trial or even standard salvage regimens, the lower the disease burden, the easier it will be to fight the cancer back. And in phase 1 dose escalation studies, when this is biologics, so you do expect some expansion, but the same rule would apply that the lower the disease burden, the more likely that there will be a difference. So I think, if someone comes with a lower disease burden, the better the chances that this will help. Obviously, ultimately, as we are dose escalating and the first patient for dose level 2 is scheduled for September, our ultimate goal is to be able to help everyone. I mean, it's really important that we don't want to develop a strategy, a therapy that is going to be only helping a small subset of patients who have a Curie score of 2. I think we have to be able to make this thing work for everyone. Are we there yet? Not really. But we hope so. So we'll see how things go on dose level 4, or even now. I think at least the expansion data and then data from the second patient is promising. Of course, it's one patient, so we cannot speculate too much. And then I think your second question was how to guide your thought process on when to send a patient. So you can have two approaches. Obviously, I think there are now for relapse refractory, there are approaches that have known efficacy. Let's say high dose MIBG therapy that can be used. So I certainly think that this is a phase 1 study. We do not have strong anti-tumor efficacy-related data yet. Have some promising results, but it cannot be compared to something that's out of a phase 2 world already. So one approach can be that the cells are being manufactured, and then the patient goes on to get standard salvage regimens. And if those don't work, well, then the product is ready, and then you can move fast. So we actually do encourage patients to get therapy while we are making the product, because although now it takes us 9 days because of the FDA required testing that we have to perform, we still cannot infuse right away. Does this answer your question to some degree?
Perfectly. In the sense of, like you said, before we approach high dose MIBG, go to you first, give you those cells that you can begin engineering with.
Yeah.
So that the space of time that might gap us, let's say if high dose MIBG didn't work, we're working with short amount of time where burdens are increasing. So I think that answers it perfectly.
Yeah, so I think it's also going to be very individual. If someone has a late recurrence with a single bone spot, you might want to reach out to us, but we may not need to immediately go to manufacturing the product, because that is very likely to be eliminated by some of the regimens. But if there's an earlier relapse with multifocal bone disease, and I think in that case you want to be prepared.
Jason, did you want to?
Hey, Andros, that's like spectacular work. I really love it. Especially, I followed that along for the last 15 years. And
Exactly.
a lot of perseverance. Congratulations on that work. I had a theoretical question for you. So your therapy requires interaction with a bunch of other immune cells, and the idea of using it, people have talked about using immunotherapy as sort of an upfront therapy. And do you think it would be, could you envision a day where we start with immunotherapy?
Yes, absolutely. I think that, right now this is a kind of a niche therapy. Even in leukemias, relapse refractory is the only acute lymphoblastic leukemia FDA-approved group where it can be used. But now I think we are on the brink of already in leukemia, the strategy being moved up to early non-responders to the upfront. And then, of course, I think as we develop strategies that work for patients with neuroblastoma or solid tumors as a group, that certainly has to be addressed. There are some barriers, right? So right now it's a kind of boutique technique when each patient is manufactured his own product, his or her own product, and it takes time. And the cost has to come down as well. But there are numerous off-the-shelf approaches that are being developed, and I think that's going to help as well. And then ultimately, I think there will be approaches when there's not going to be outside manufacturing of the body, and the patient and the cells will be engineered inside the body, and it will be redirected, which is, I think, the ultimate future of cell therapies.
Okay. Yeah. One more question, Dr. Kushner.
Yeah, I repeat also how much value all this work, and can't imagine all the work going behind it. A quick question though is, can you speculate on why this CAR T cells have been so effective for the liquid tumors, ALL, for example, and things are lagging behind in terms of solid tumors, and maybe speculate whether there's an issue in terms of trafficking into soft tissue masses and so on, and also maybe a corollary in terms of evaluating responses in the bone marrow.
Yeah, so I think you are spot on that there's a huge lag behind the data that's coming out for solid tumor CAR T cell or CAR NK cell based approaches compared to whether it's B cell leukemias or now multiple myelomas. I think one is the target antigen. For solid tumors, we don't have that good or that many attractive targets. I think GD2 may be one, at least thus far it seems to be safe, and we don't see the either in this trial or the two previous CAR T cell, GD2 CAR T cell trial, we didn't see toxicities related to pain. Trafficking is a big one, I agree. In solid tumors, there are certain chemokines that are being secreted. So with the NKT cell approach, NKTs do express receptors that will pick up CCL2 and CCL20, which is produced by neuroblastoma, so they will traffic there. But not all T-cell-based strategies will have that advantage. So I think that's certainly a barrier, trafficking. And the other thing is just the immunosuppressive tumor microenvironment. It's very complex. You have myeloid cells, MDSCs, TAMs, however you want to call them. You have other stromal cells, cancer-associated fibroblasts, all of them trying to turn off these effector cells as they get there. And murine models are very helpful, but they cannot recapitulate the human disease. So we do need to have some biopsy samples and to understand what's happening in the microenvironment.
But also about the bone marrow. So I don't think bone marrow would be an area where trafficking would be an issue. And also, I'm not sure the microenvironment would be an issue, but maybe I'm wrong. What is your take on that?
Yeah, so I think, metastatic sites, so the primary, I think so depending on where the tumor is, there is some data that the microenvironment might be a little bit different in the bone marrow, or the primary tumor. So the immune escape mechanisms that the cancer cells will be using are probably different. So for neuroblastoma patients with bone marrow disease, I think for CAR T cells, you're right, they should be trafficking to the bone marrow. The last trial, GRAIN trial, that TCH at least didn't really have a major impact on patients with neuroblastoma. Here we do see that they go to the CAR NKT cells do go to the bone marrows. We have not had a patient where, well, the first patient had bone marrow disease before and after, but also had a huge burden everywhere else, and so we didn't see a major impact there. The second patient did not have bone marrow disease, so besides finding the cells in the bone marrow, which is promising, we can't say whether it's working there or not yet, but hopefully we'll be able to answer.
No, just quickly about the presence of the CAR T cells in the bone marrow, but that's is that different from in the blood? I mean, blood goes through the bone marrow space.
Yeah.
Is there anything particular, are you seeing any difference in checking the levels in the peripheral circulation versus in the bone marrow?
Yeah, so it seemed like that there is an enrichment in the bone marrow for in this in the lower panel. So there's a pretty good amount of NKT cells there. In the peripheral blood, we didn't see that many.
Okay.
But it's tricky to assess NKT cells expansion in the peripheral blood because we do know that that's kind of tip of the iceberg because they should be trafficking to the tissues. So, directly comparing them with the bone marrow, we expect them to be out in the tissues. So it's hard to know. I think it will be very nice if we can show that there's a patient with bone marrow positive disease and then maybe that bone marrow is cleared. That would be a real evidence. We'll have to get there.
Okay. Thank you.
Thank you.
Thank you, Dr. Heczey. And I did want to mention, too, that CNCF is providing grants to Dr. Heczey's trial for travel assistance. So if anybody is eligible to be on the trial and you need assistance, that CNCF will be providing travel grants for it. Thank you, Dr. Heczey. Our next speaker is Dr. Ami Desai. I told you I was going to mispronounce it. Ami Desai from the University of Chicago Comer Children's Hospital. And you can go ahead. Yeah. Is he taking our microphone away?
No, I would never do that.
Normally we would start off, with either Sue or Ami doing the introduction on neuroblastoma, just so for new patients and everything, you kind of get the basics of neuroblastoma. Because of Dr. Heczey's travel, we moved it down. So Ami will do the introduction, staging, markers, and things of neuroblastoma. So Dr. Ami Desai.
Good morning, everyone. It's a pleasure to be here today. I want to thank Pat and the CNCF for everything that they do. And today, I will be discussing really the basics of neuroblastoma therapy and some basic principles of neuroblastoma, staging and markers. And hopefully some of the concepts we review today will be helpful and set the foundation for other talks that you hear later today and tomorrow. So neuroblastoma is a pediatric solid tumor. It originates from neural crest tissue and basically from tissue that leads to the development of a sympathetic nervous system. So this tissue is in the adrenal medulla. It's also in the sympathetic ganglia. So essentially, neuroblastoma can develop anywhere from your neck into your pelvis and again in the adrenal glands as depicted in the pictures on the right. And it is described as a small round blue cell tumor, and that is because of how it looks under the microscope. Out of the pediatric cancers in children under 15 years of age, neuroblastoma is actually in the top 3 with an incidence of about 10 per million. So I wanted to review a little bit about the epidemiology. It is the most common solid extracranial malignancy in children. About 750 new cases per year. It makes up about 7% of all childhood cancers and about 15% of childhood cancer mortality. So again, 7% of childhood cancers, but a disproportionate amount of childhood cancer mortality. The median age at diagnosis is about 18 months. However, more than 90% of the cases are actually detected by 10 years of age. And as you can see on the right, here is a plot of age-specific incidence rates. And as you can see, the majority of cases are really in the first 2 years of life and start trickling off by age 10. It is rare in adolescents and young adults. And when it does appear in older children and young adults, it tends to have a different course than what we see in younger children. These patients tend to be a little bit more chemo-resistant, have more of an indolent course, and unfortunately don't respond to therapy as well as some of the younger